So it's a pleasure to introduce Dr. Anand Rajendran. He's an ophthalmologist at the Aravinda Eye Hospital. Previously, he was in the same hospital in Madurai, and for the last few years in Chennai. He's, I think, the head of the vitreoretinal unit there. He's like the other medical practitioners we've seen previously, both a clinician and an active researcher. Is, I think, the chair of the scientific committee of the Vitreoretinal Society of India, and widely published in his field. And in addition, he was my classmate and friend since UKG, but I reconnected with him. I realized his interest in this field only recently. So over to you, Anand.
Okay, thank you, Rahul. It's an absolute honor, pleasure, and a privilege to be, addressing an august audience here. This is not something we retina specialists, ophthalmologists do regularly. It's going to be a challenge, and I'll try to make the best of it. So I'm going to be talking to you today about macular maladies, protean pathologies, and AI predictive potential. I'm going to be talking about a bunch of pathologies, but focusing largely on age-related macular degeneration, which is a big problem, as you'll see. So the preamble first, just internal anatomy of the eye. Eye has three layers. There's this outer fibrous layer called the sclera. You can see there. Then you have the choroid, which is the middle vascular layer, which is there at the back of the eye, and it continues anteriorly in the front as the ciliary body and the iris. And you have the cornea too. And the inner sensory layer, neural layer, which is the retina. And when we see objects, light from these objects go through the refracting elements, the cornea, the lens, pupil, through a transparent gel, the vitreous, and focuses on the retina. And the retina is therefore obviously the inner neural layer of the eye and contains the photoreceptors, rods and cones, which are sensitive to light. And embryologically, the retina develops and is part of the central nervous system. So the neural tube, which goes on to form the brain, extravasates and forms the retina. And obviously, this is where the function of the eye is realized, which is basically converting physical energy into neural or biological energy, nerve impulses, and that is transmitted to the brain via the optic nerve. So the macula, which we are going to be focused upon in the previous talk, Rajiv talked about diabetic retinopathy, which affects, apart from the macula, large parts of peripheral retina. But macula is where actual vision is really, realized. And focused light is trained on the macula, which is at the center of the retina. And this is where you have the highest concentration of these photoreceptors, as you can see here, and therefore the highest visual sensitivity and acuity. In the center of the macula is the fovea, which is a depression or a dimpling or an umbilication, as you can see here. And this is the central 1.5 millimeters or the central 5 degrees and the area of the absolute highest visual acuity. And as you go away from that, you have the parafovea and the perifovea, where there's receding levels of visual acuity. Now, what are the key outcomes that we assess in macular pathologies? Obviously, function in terms of vision, visual acuity gain or loss in number of letters, and the central retinal thickness, which is the anatomy. So you have structure and anatomy being assessed. So what is age-related macular degeneration, or AMD? And this is the acronym that I'm going to be using. So AMD is a disease of the aging affecting the macula. Symptoms associated are reduced vision, which is a gross loss in the number of lines you can read on that Snellen reading chart, as well as a distortion or waviness of that field. So while you may be able to read the letters, there may be a lot of waviness or blurring. And like I said, 50 is the magic number which we are kind of focused on. And as you can see here in that cartoon, this is the normal macula. And the macular degeneration has two types, the dry form, and we'll be seeing more of this in detail a little later, and the wet form, where you have a lot of bleeding and fluid and exudation. We'll see more about that. So strictly speaking, from a clinician's point of view, age-related macular degeneration is defined as a disorder of the macula in patient over 50 years of age, characterized by the presence of any of these, presence of at least intermediate sized drusen, 63 to 124 microns. These numbers are important. RP abnormalities, hypo or hyperpigmentation, reticular pseudodruseness, again, we'll talk about these, and presence of any of the late, more malignant features, malicious features, geographic atrophy, or choroidal neovascularization. Now, why are we focused and why am I talking about AMD at all? So it has been recognized very clearly that AMD is a leading cause of severe and irreversible vision loss globally. Affects 10 to 13% patients of adults over 65 years of age. Number one cause of blindness in the developed countries. Almost 288 million patients are expected to be there of AMD by 2040. And 90% of them, of this AMD is associated of associated AMD vision loss is due to neovascular AMD, which is the wet form. And we'll be defining this also. So this increasing prevalence of AMD is obviously a substantial burden to global healthcare. And as you can see from 2014 to 2040, you can see the numbers shooting up. And unfortunately, as we've seen with diabetes also, the numbers are more in our part of the world. As you can see, Asia is going to be contributing to a massive proportion. Right now, we have about 196 million. By 2040, it's going to shoot up to 288 million. So what about AMD in India? Because studies have shown, and Rajiv has done great work here. In urban India, the prevalence is about 16.37%. In rural India, it's a little more, 20.91%. Incident prevalence of late AMD is more or less the same. Now, the gory fact file about advanced forms of AMD. They present with severe vision loss percentage of about 21%. Means 1 in 5 patients will have severe vision loss when they present, and down 6 months from there, from the point that you see. And by 3 years, it's going to double, 42% going to have severe vision loss. Visual acuity less than 6/60, which is roughly 50% vision, 20% at baseline, going to skyrocket up to 76% by 3 years. And there's a doubling of the visual angle, which is the angle that an object that you focus upon, subtends on the retina. And on average, 1 to 3 lines are lost by 3 months, and 3 to 4 lines by a year. So that's how serious things can be. And what about the fellow eye? If one eye has advanced AMD, with neovascular AMD, 12.2% of cases in the fellow eye by 1 year, and 26.8% by 4 years. And almost half the cases, more than half the cases, will have CN choroidal neovascularization in 5 years. So this is the erstwhile clinical classification that one always refers to. A lot of studies are based on this. So this came through in at the turn of the millennium, about 2001. So you have category 1, no AMD, less than 5 small drusen in one or both eyes, and I will define this later. What these entities are, the drusen, etc. Category 2, early AMD, multiple small intermediate drusen in one or both eyes, pigment abnormalities in one or both eyes, early AMD, category 2. Category 3, little more serious, intermediate AMD, intermediate or large drusens, and geographic atrophy not involving the central macula. Category 4, most devastating type to have, late or advanced AMD is neovascular AMD or geographic atrophy, but this time involving the macula. And this classification, the clinical classification, came from the Beckman Macular Initiative Center. This came in 2030, about 12 years after the ARED study, which was more or less the same, just gave a few more numbers to that. I won't go through that. These are the risk factors that one needs to keep in mind. The stronger ones being positive family history, smoking, hypertension, the usual suspects. Weaker ones being hypermetropia, that is having a plus power. Females, blue iris, cataract surgery, large cup disc ratio, which is the excavation of your optic nerve head, as you see it on FAS when you look, and this predisposes to another condition called glaucoma. Protective factors. There are certain protective factors which have been recognized. Black race, increased intake of specific fats, unsaturated fatty acids, linoleic acid, fish, dark green leafy vegetables, and higher serum carotenoids. All these help. Now, I'm just going to give you how the macula, functions. Just a bit of a graphic. So the retina receives nutrients and oxygen from the layers below the choroid. As you can see, it disposes waste material as well as fluids into this receptacle, the choroid. And with age-related effects start manifesting in the choroid and the Brooks membrane, which is a connective tissue membrane below the retinal pigment epithelium. And there is therefore impaired transport of oxygen in and out of waste materials. And therefore, there is reduced RPE phagocytosis and accumulation of this waste material called drusen just below the retinal pigment epithelium. And this is the start of the nidus for dry age-related macular degeneration. Now, let's see what happens to the eye as it ages. So this is a young eye. This is the kind of picture all of you will be having at the microcellular level. This is the retinal pigment epithelium. These stacks of discs here are part of the photoreceptors, and this microvilli are the interdigitations of the RPE outer basement membrane with the Brooks membrane, and you have here the inner capillary zone and the outer capillary zone, and all this is well and good. Now, as the eye starts aging around 50, what will start happening here is the photoreceptors will start degenerating. You'll see that at the apex, those microvilli have started getting eroded. There's basal laminar deposits, the destructive material starting to get deposited here. And you have these choroidal membranous basal bodies and focal laminar subcapsular deposits happening. So right now, still, there's no real visual loss that the patient can appreciate, but the eye is beginning to age. Now you see what's happening. This is where pathology is starting. At early age-related maculopathy, the photoreceptors, inner segments, the cone inner segments start degenerating. There's membranous debris being deposited at the apex of the RP as well as at the base. And you can see that the choroidal vessels have started to shrivel. By the time you get to late AMD, there's an almost complete destruction of the cone inner segments. There's a lot of membranous debris here. You can see those microvilli completely gone. The cell is filled with waste material. The nuclei is almost marginalized. And you find shrinking of the choriocapillaris and the vasculature below. Now, this is just an example of pictures of one particular individual longitudinally. You see at 68 years, things look okay. At 73, okay, you say it's still kind of okay. At 77 years, look what's happening here. You can see this RP hyperpigmentation, first giveaway sign. There's a fair amount of that. And at 79 years, there is some clarification. There's some disappearance. So you're thinking, okay, maybe he's getting better spontaneously. But no, what's actually happening is the cells are dying off and those pigments are going off. So that's an imminent sign that this man is hurtling towards dry age-related macular degeneration. Look what happens now at 81. You can see these are the upper two panels are taken at the same time. This is the one with the greens with the green filter. You can see that there is some denudation, and what you're seeing through is the underlying choroidal vessels being seen through and seen better on the green with the green filter. And almost immediately within a year, see how he hurtles towards a fairly large area of geographic atrophy. So the cells, the RP cells have completely gone in that central area, and you can see the larger bore choroidal vessels being seen through. And 2 years later, that area has really increased, and you can see, so this patient virtually not going to see in the central ovoid area. So the two types of AMD, dry and wet. Dry is non-exudative or non-neovascular, wet is exudative or neovascular. And this is the tree of AMD, you might like to call it that way. It begins with, drusens. This is, of course, a simplification. Drusens, here there's no AMD yet. But drusens with vision loss, now you start having dry AMD. And this is about 10 years from the onset of drusens. And then it can go towards dry degeneration, geographic atrophy, or towards choroidal neovascular membranes, the wet or malignant neovascular AMD, occult, and then classic CNVMs, and then finally a disciform macular scar. And we'll again see examples. So the difference between dry and wet, dry is more common, 80 to 90% of disease cases, but this is slow onset, insidious, not that very dangerous. Wet form, much smaller percentage, 10 to 20%, but associated with rapid, severe vision loss. And dry AMD, although it's 80 to 90%, it's responsible only for 10 to 20% of AMD-related vision loss. On the other hand, wet AMD, 10 to 20% is responsible for 80 to 90% of AMD visual loss, clearly the more dangerous one. And dry AMD is characterized, as I said, by geographic atrophy, and this can morph alongside and into wet AMD. The main clinical features being choroidal neovascularization will typify this. And the treatment would be lifestyle advice or nutritional supplements. On the wet AMD side, anti-VEGF or anti-vascular endothelial factor growth injections. So we'll see that. So dry AMD characterized by these small hard drusens, large soft drusens, focal pigment epithelial degeneration, focal hyperpigmentation, geographic atrophy. We'll see this. These are the small hard drusens, very discrete, very well-defined, hard yellow-white deposits external to the RP and may or may not be age-related depending on the involvement of visual loss. And these are less than 63 microns in diameter. And on the OCT, which is cross-sectional imaging, like you have CT scan of the brain, you have optical coherence tomography, and you can see that serrated margin where the RP is, serrated. So this drusenoid material is external to the RP. An example of a large soft drusen, these are greater than 63 microns. These are ill-defined borders, as opposed to what you saw with hard drusens. Cluster and they merge with one another, and there is confluence here. Another example where you have a large foveal soft drusen, and you see the OCT here with a large central bump right here. Okay, rounded bumps, and they are all merging with each other. Reticular pseudodrusens, which I had mentioned, this is like a rash of yellow spots, as you can see here. It's different from what you saw with hard drusens, which are separate. And these, as you can see here on the OCT, these are sitting on top of the RP, not under the RP as with true drusens. So pseudodrusens are those where you have subretinal, but drusenoid deposits sitting on top of the RP. And this is the focal hyperpigmentation you saw in the gentleman with the longitudinal cross-sectional pigment clumping at the level of the outer retina. This can be various shapes, punctate linear reticular, and another one here, and you can see the OCT. Geographic atrophy. This is what is the most debilitating form of dry AMD in its advanced form. There's atrophy also of the underlying choriocapillaris, so that the large choroidal vessels can be seen through. And this is officially called GA when it's 175 microns or more in diameter. This is something that comes as a consensus definition for trials. And this is another example. You can see the RP is completely gone here. And this is the disciform scar, which is the absolute end stage of neovascular degeneration. And you can see on the OCT, the scar here and the degenerative cysts above that. So this is end stage disease for neovascular AMD. So just again, the tree of AMD, like I said, drusens vision loss, they can branch left and have geographic atrophy here, dry AMD, or it can go in this direction and have wet AMD, disciform scar here, and you see that example. So what about the rates, temporal profile? So again, that same study, the group which gave the clinical classification in 2013, they found that with no drusens, the loss of vision at 10 years, the risk of developing advanced AMD was almost zero if you had no drusens. But when you start having small drusens, as you can see here, that goes up to about 2 to 3%. When you have those medium large soft drusens in one eye, then the risk of developing advanced AMD in 10 years is about 3 to 4%. But then when you have medium drusens in both eyes, that shoots up to about 12%. So this is where AMD and machine learning programs can help us. If you can look at large populations and pick out these early, you can focus on those populations, identify those people who might go 10 years down the line into advanced AMD. Now, what about the fellow eye status? One eye is lost or has advanced AMD. What about the other eye? What is going to be the fate of the fellow eye? So you see here, when one eye has advanced AMD, no or small drusens in the fellow eye, that eye in 10 years down, it goes up to about 2 to 3%. When you have medium drusens, it goes up to 20%, the risk of getting advanced AMD, this fellow eye. You have one risk factor, and there's a big bunch, I won't be going to that. That risk goes up to about 45%. And then when you have two risk factors, it goes up to about 80%. So that's how important this is. So some example, and this is a cartoon which shows the evolution of wet or neovascular AMD. So you have choroidal vessels, abnormal pathological choroidal vessels, first smoldering and developing under that Bruch's membrane, as you can see here. Then it breaks through the Bruch's membrane, and there's already the drusen there. And then see what happens as it spreads under that RP and around the drusen. Laterally, the drusen sometimes actually starts resorbing. So when you're seeing the patient and you've seen this patient for 4 or 5 years and you've seen a lot of drusen there, and suddenly you find the drusen going, you should, raise a red flag that maybe this guy is developing the more malignant form of neovascular macular degeneration. So you see the neovascularization developing, and then this goes laterally, and then it starts exuding fluid, and that RP is getting lifted up, and then the RP can break through, and the vasculature goes through that and spreads laterally, and then you get choroidal neovascularization becoming subretinal vascularization. So these are clinical examples and pictures. You can see that this yellowish gray subretinal membrane, the subretinal fluid, there's hemorrhages, there's exudates, as you can see here. So this is how neovascular AMD, full-blown choroidal neovascularization would look to us clinicians. The diagnostics. So fluorescein, fundus fluorescein angiography and ICG, indocyanine green angiography is used. Now it's slightly coming down as we're getting better and with non-invasive modalities like OCT, which is the key investigative modality for us. Rajiv talked about this in diabetic macular edema, and fundus autofluorescence, which is like a metabolic mapping. And of course, let's not forget that fundus photos are, of course, the basis and the key kernel of our diagnostic modalities. And a new kid on the block, OCT angiography, which is basically dye-less angiography. So fundus fluorescein angiography, we have classified CNVMs traditionally as classic or occult, and in occult we have two categories, fibrovascular late leakage. And then you don't always get these very definitive, differentiations. You have predominantly classic here. You have the classic CNVM, a well-defined network out there, and occult, which is not well-defined, which is a little fuzzy, but you know where it's coming from. So these are fibrovascular. And then you have late leakage from unknown source. As you can see here, it's not very, the leakage, the source is not very clear. Then, as you have in most of the cases, it's a mixed CNVM. The component that is predominant is the predominantly classic one here. And you can see the larger component is the predominantly classic component. RAP is another component here. You see this here, the abnormal vasculature is coming from the retinal circulation, as you can see right there. With OCT also, you can classify them. Type 1 is occult, where the RP is lifted up, and type 2 is, or the classic CNVM is the one where this neovascularization is sitting atop the RP. The RP is not lifted up, as you can see here. And this is RAP, where you can see that the neovasculature is coming from the retina. There's a lot of leakage here. There's a PED, and there's fluid atop that. And you can see on the ICG, there's the origin of that neovascularization starting from the retinal circulation. And this is the feeding artery. And this is in the late phase, you can see the draining venule. So this is a 3D volume scan. Let's hope the video works. Yeah, it does. So you can see on the 3D volume scan how the different compartments of fluid are seen. So indocyanine green angiography is another modality used more to differentiate from polypoidal choroidal vasculopathy, which is another differential. You can see on the fluorescein up here, it's all white out here, but with ICG, ICG is great for looking at the choroidal vasculature. So you can pick out that hotspot and treat it focally there. And you can combine both of these together. You can see the retinal vascular circulation is shown better with the fluorescein, and the ICG shows the choroidal vasculature better. Then you can see the different characteristics. And it's used mainly for differentiating polypoidal choroidal vasculopathy, is a key differential for AMD. And you can see in polypoidal choroidal vasculopathy, which is different from neovascular AMD, you can see these branching vascular networks terminating in these bulbous polyps. So this is a different morphology, and knowing this is important. Fundus autofluorescence is a non-invasive imaging modality, which is basically, like I said, metabolic mapping of the lipofuscin in the RP and other fluorophores in the retina and subneurosensory spaces. So this is great for looking at geographic atrophy and progression. And as you can see here, in an area where there is hyper autofluorescence, this suggests that there's metabolic activity, and this area is going to die out. As you can see in this 5-year progression, there was increase at the GA at the area where there was hyper autofluorescence earlier. So why is this important? Why is this useful, especially in AI models? You can look at the margin of the area of geographic atrophy and see whether this patient is going to progress fast or slow. So when you don't have any increased autofluorescence in the margin, they're going to be slow progressors. Then when you look at if it's increased only at the margins, if it's a focal single or few spots, you're not worried. These are slow progressors. If they're banded, then and almost continuous around this, then that is a rapid progressor, and we don't have too much data of it's patchy. But if it's increased all around and there is a lot of different patterns like fine granular branching, etc., and it's going beyond, then these are rapid progressors and you're worried. OCT angiography, like I mentioned, it's dye-less angiography. You get this all these vascular patterns without injecting a dye. That's great. So this is basically a clear depth resolved dye-less visualization of both retinal and choroidal vasculature, as you can see here. So this is retinal vasculature. You can see the retinal vasculature here and the choroidal vasculature below, according to the depth that you're looking at. And this is based on the principle of motion contrast imaging. Basically, the laser maps the RBC movement over time by comparing sequential B scans, OCT B scans at 4 registered point locations. And there are different algorithms. I won't go into them. So these are the patterns that you can see. You can see get a C-fan pattern, a Medusa head pattern, ill-defined patterns, or long filamentous patterns. And these are great for, again, AI tools. And you can see the regression. So this is before anti-VEGF injection, and this is post-anti-VEGF injection. You can see there's a reduced vascular density, reduced small branching vessels, and larger units are recalcitrant because they're already mature. But this finer branches, the growing ones, they go off with that anti-VEGF injection. And you can see on the structural OCT the corresponding regression of the fluid and the settling down of that CNV. Now, FATS did some good work, and I'd just like to highlight this one paper where they looked at the changes in OCT angiography, 2 types of CNVM, and in response to anti-VEGF treatment. And they tried to see whether OCT angiography lends itself to mathematical modeling, and they found that it was useful in monitoring CNV activity. They looked at various vascular parameters, area, the total length of the CNV vascular segments, overall number, fractal dimension, and they found that with cyclic regression and recurrence, with anti-VEGF injections, these little neovascular sprouts on that neovascular on their mathematical model also correspondingly changed. So diagnostics, why are they needed, and what is the relevance, especially for AI models? Of course, for diagnosing disease and staging it, but these can lend themselves to AI model data sets, and that's a great thing. And we hope that with further collaborations we can do things. So these are the differentials that one needs to and can keep in mind, and these mimic AMD, and these are where we hope that with AI robust models we'll be able to pick these out and differentiate them. With therapy for dry AMD, like I mentioned, it's mainly lifestyle as well as nutritional supplementation. These are the indications with extensive intermediate drusen, 1 large drusen, non-central GA. This is the dosage: vitamin C 500 micrograms, vitamin E 400 international units, zinc 80 milligrams, copper 2 milligrams, beta carotene 15 milligrams. So this was the original ARED study. But they found that with that 80 milligrams zinc, there were genitourinary issues, and that had to be scaled down to 25 milligrams. Beta carotene, people who had who were smokers had an increased risk of lung cancer. It was replaced by lutein and zeaxanthin. And they also found additionally beneficial effect of omega-3 long-chain polyunsaturated fatty acids, 350 milligrams docosahexaenoic acid, 650 milligrams icosapentaenoic acid. So about wet AMD, first we had no treatment before 80s. People had neovascular AMD, we would say bye-bye, sorry, we can't help you. But then with time, over the last 20 years, it has moved from thermal lasers to photodynamic therapy, anti-VEGF therapy, which are injections. And anti-VEGF injections, these agents, they've had a massive impact in the reduction of global blindness. If you see these European studies, the first 3 graphs on the left, almost 50% reduction in the incidence of blindness purely because of these anti-VEGF agents. That's how significant they've been. And the theoretical modeling in the US showed that that number was as high as 72% in the US. And where was the maximum impact seen? With age-related macular degeneration. So you see that graph here, the greatest drop in incidence of blindness was in AMD-related blindness. And this is the effect on the other non-AMD causes. So that's how important anti-VEGF agents have been in the management of AMD and global blindness. So these are the 3 agents: ranibizumab, proprietarily Accentrix in India, Lucentis outside India, aflibercept Eylea, bevacizumab, Avastin. And this is how it's given: injection into the eye, into the vitreous. So you're depositing that agent there. And these are the 3 drugs. And this is ranibizumab, bevacizumab, and aflibercept. I won't go into the molecular. This thing is suffice it to say that ranibizumab and bevacizumab address all VEGF-A isoforms, whereas aflibercept is a little stronger. Address also VEGF-B and platelet growth factor. These are the doses. So this is how we drape the patient, withdraw the drug, mark where we have to, which is 3, 3.5, or 4 millimeters, and then deliver the drug into the eye. So this is how hopefully we would like to see all our patients. This is CN type 1 CNV regressing, type 2 CNV regressing. But more often than not, it requires more than 1 injection. These injections usually last only 4 to 6 weeks inside the eye. And progressively, you need multiple injections. You can see that with multiple injections, that CNV slowly settling down. Now, ARMD and AI predictive potential, you see the contribution In AMD, you see for identification, this is machine learning based, with use for classification of disease, staging and typing and screening. Deep learning based, again, for classification, also for detection, and for predicting treatment response, which is very important. It's mostly deep learning based prediction of clinical demographic data and disease progression, as well as anti-VEGF outcomes. So applications from a clinician's perspective, data input to AI models can be with numerical or categorical, which is basically our clinical data, imaging, fundus photographs, and OCT. Now we are beginning to look at volume scans too, and we're also beginning to look at autofluorescence. So there are a huge bunch of papers which have come in for AMD, and these are the models which are looking at detecting AMD, and also for diagnosing AMD. And very interesting, this is important, AI models looking at predicting conversion of dry AMD to wet AMD. This is something we are very interested in. This is what we really need. And Yim et al. Has done a great job looking with deep learning segmentation. Also, very importantly, AI models for predicting anti-VEGF treatment response and progression of AMD. So this is what we're looking for. And there are definitely robust models coming up based on convolutional neural networks. So we've been we just started off in a study on validation of an offline AI system integrated on a smartphone fundus camera for AMD screening. We're doing it in collaboration with Remedio Systems at Chennai. And this is based on certain papers that we already published with diabetic retinopathy. And the aim is to assess the performance of an automated tool for AMD screening using AI deployed offline on a smartphone-based camera. We get clinical data, do the anterior segment and the posterior segment evaluation. The clinician looks at the fundus photos and the OCT. The AI arm tries to look at these images and decide whether they are referable or non-referable. And this is we use the ARIDS classification as well as the standard OCT grading, and we come up with these final grades. So that's work in progress. So the strategies to optimize neovascular AMD, there are a bunch, but we are focused on this area, which is use of artificial intelligence. We recognize it's important. Now coming to another one, another pathology. So this was the main pathology that I really want to put in your minds today about age-related macular degeneration, why it needs to be addressed. Another pathology which is seen more in younger patients is central serous chorioretinopathy. So this is, here you have serous detachments of the neurosensory retina with RPE leaks, and this is often associated focal detachments of an altered RPE. It is the fourth most common retinal pathology after diabetic retinopathy, age-related macular degeneration, and retinal vascular occlusion. So that's why it's that important. Males have a higher prevalence, 6 times more incidence, bimodals in the 20s and the 40s. So a disease more of the younger, while AMD was of the maculopathy of the aged, this is a disease more of the young and associate more with stress that's important in today's day. Also has ethnic implications, high incidence in Asians, our part of the world, Caucasians and Hispanics. So this is the type you can get an acute CSER, which is the classic form where it can happen in days or weeks. The symptoms are mild to moderate acuity reduction, a little waviness, metamorphopsia, a central field effect. People come in typically saying, "This my central vision, I can see a black 1 rupee coin kind of black shadow there, and it's continuously moving." So that is seen, this localized subretinal fluid, the focal leaks we'll talk about, and sometimes it can go away by itself with reduction of stress. So this is the picture, this is how it would look like, and this is on the fluorescein angiogram, you'll see an ink blot leak, a small start, and then it increases. And or you can see a more dramatic but less common smokestack leak, the leak, because of convection currents, that dye is rising up in that subretinal blister fluid. And the chronic form is also seen. You have untreated multiple recurrent episodes. You can have a diffuse retinal epitheliopathy. You can have a chronic fluid there leading to atrophic tracts. On the angiogram, you would have these blotted mottled hypofluorescence. And you can also have non-resolving or recurrent CSRs or inactive CSERs. Why does this happen? It's because of mechanical stress of the fluid under the RP, resulting from increased intrachoroidal pressure. So BP, hypertension, stress, all that causes the increased vascular pressure. And there's reduced RP adhesion, and there's a blowout. There can be an alteration of the hydrodynamic RP regulation and RP atrophy choriocapillaris hypoperfusion. Stress plays an important role. So this is what we're seeing a lot of the IT population, a lot of truck drivers who drive through the night, people who have irregular sleeping patterns, This is something we see very commonly. Also, people who use steroids, external steroids, facial creams, fairness creams. We are seeing a lot of this. So steroids and stress, these are two important factors. A thick choroid, I said that everybody sits, our retina sits on a choroid. When the thickness on some people genetically have thickened choroids, and therefore the choroidal pressure, vascular pressure is more, and these people are typically more prone to this condition. So these are some other atypical, more extreme manifestations. A teardrop CSR, you see the gravitational tract fluid tracking down. It can mimic inflammatory choroidal disease. Choroiditis mimics. The angiogram shows this. You can see a leak here, and you can see it snaking through like this because of the fibrin under the retina. Or it can mimic a choroidal neovascular. When you look at the picture on the left, the fundus picture, you'll think you're dealing with a neovascular AMD in a young patient. But actually, it's a choroidal neovascular. It's a CSCR, because you see the leak increasing slowly. It's not the fluorescein angiogram, which I showed you earlier. You can also mimic diabetic macular edemas. You see here, this is a patient who was diabetic, but this fluid came up and there was exudates. They were thinking diabetic macular edema, but when we did tests and we followed the patient, this was CSCR. We treated the patient photodynamic therapy, and you see it resolved well. You can also present with inferior detachments. Although I said it's a macular disease, in severe cases, there can be an entire detachment of the inferior retina with neovascularization in the periphery as well as on the iris in front. Management is with focal lasers if it is a focal leak, but if it's a diffuse leak, we do something called photodynamic therapy. We give in an injection to the arm, and we apply a cold laser to the eye. Other alternatives are also there: transpupillary thermotherapy, subthreshold micropulse laser. If CSCR develops neovascularization, then we given the anti-VEGF injections that I talked about. So this is an example of a CSCR case where we're given this thing, photodynamic therapy, and you can see the slow reduction. The first month itself, all that subretinal fluid goes, that PED, that bump, reduces inside, and then by 6 months, it's all done, and the patient gets almost 6 exposures. Another conventional case with conventional green laser, you can see this little spot here, the leak here, treated with the focal one-spot laser, and then complete resolution. And you can see the trace of that spot here on autofluorescence. Whereas when we use subthreshold micropulse yellow laser, which is a colder laser, it is lesser tissue toxic effect. You see there is resolution, but interestingly, there is no trace or no tissue toxicity on the autofluorescence. So it's a little better to use this. Again, a few studies. I'll just quote this one study from Howe, who looked at a number of cases from the PLACE trial. He looked at comparing retinal function perimetry versus retinal morphology, compared fundus controlled perimetry data aligned to SDOCT to extract retinal layer thickness and refractivity values. And he concluded that localized retinal sensitivity can be inferred from retinal structure in CSE using machine learning. So that was something very exciting to come across. And there's also this paper from Zhu, who, again, from China, looked at predicting visual and retinal structural outcomes with AI. They used one particular center, the Zhongshan Center, to develop the training set, and then they applied it to another center, the Xiamen Center, 64 eyes for the test set. They used 6 different machine learning algorithms and a blending algorithm. This is how they went about it. And they looked at data predictions, equity, and OCT predictions. And they found that they were fairly accurate. And the synthetic OCT images were only 5%. They could really make out that 5% different from the actually ground truth images. And conclusion was that the study did establish that this was a fairly reliable method of predicting CSAR laser outcomes anatomically 6 months in advance. So coming to the final one, so those two were medical. Now this is surgical. So sometimes, unfortunately, the macula can develop sudden breaks right in the center. So this is a macular hole right there. And this is the staging. You can see this is the original gas staging 95. Came in, and this in stage 2, the vitreous above is just pulling, tugging at that edge of the macula. Stage 3, this is broken and there's an operculum here. Stage 4, you find it's a full thickness macular hole. And basically what we do is we clear, we go in with 3 ports, we clear the vitreous out there, remove that entire gel, stain the uppermost layer, which is the internal limiting membrane ILM with this dye brilliant blue G. Proceed with ILM peeling. So you're making a 10-layered retina, 9 layers. and then we put in gas, replace the liquid saline with air, and then inject gas, replace it with a long-acting gas. And you can have a perfect closure, which is type 1, or a closure with a 4-wheel defect, especially when these are chronic. It can be this type 2 kind of closure. So this is a typical case where there's a good result with visual acuity improvement. You can also have macular holes with retinal detachments, and you need to do more extensive surgery, and you can see the post-op result. And this is a diabetic case, diabetic tractional detachment causing a hole, tractional hole, and then with surgery, and we put in silicone oil, and you can see a good anatomical result. Sometimes post-trauma, you can get this kind of thing. So this is a patient who had a cricket ball trauma injury. You can see this retinal atrophy out there. You can see this degeneration and a traction hole. And when the line scan is passing through this, and you can see the retinal atrophy, the thinning of the retinal atrophy in this part where there is this discoloration. So there's not much we can do for acuity when there is a retinal atrophy alongside. So it would be great if these kind of images can also be looked at in AI models. So there are many indices to look at, the outcomes. This one which came in, one of the first to come in, the whole form factor, HFF, which is basically the sum of the two sides of a trapezium, which is drawn in that macular hole of the OCT and divided by the base length, C plus D, and higher the whole form factor, better the visual acuity outcome. So prognosticators, macular hole size, if it is less than 400 microns, good. More than 800, not so good. Duration more than 6 months, outcomes will be poorer. The starting pre-op poor visual acuity usually ended up with poor acuity at the with surgery. Type 2 closures did not have good acuity outcomes. Macular hole indices help understand. And post-op integrity of this inner segment, outer segment junction here, or these outer segment cost outer or ELM, this outer retinal structures. When you look at them, if that integrity is broken, then the acuity outcomes are not so great. So there are studies which have looked at AI for macular hole surgery. So this is one particular one which kind of caught my eye. Obata from Japan, they looked at creating a model for prediction of post-op acuity after vitrectomy for macular hole using preoperative images and using deep learning or based AI. And they found that preoperative OCT images with corresponding acuity were used here to train the original DL network. They created a model for predicting post-op acuity from these pre-op factors. And they found that the deep learning and the multivariate models had precision values of 46 and 40%, and predicted post-op values on the basis of the deep learning and on pre-op acuity, and macular holes correlated well with acute post-operative acuity at 6 months. So this is pretty interesting because it's not always possible to predict outcomes, and so as surgeons, we would love to have AI help us with, predicting as well as telling the patients and counseling them. So basically challenges with AI is, the data is not from a heterogeneous population. So we ideally need training data sets that are large and diverse. We need these tools, and unless they are, then there's limited utility. Would it lead to a de-skilling of physicians? This is a moot point. It disregards patient psychosocial aspects. Like I said, I think Anurag mentioned at the top that you need that message coming from a human at the end of the day. AI models which are there currently are good for single disease or mono disease monitoring. But handling multiple pathologies, whether you need multiple AI models working simultaneously, looking at the effect of various diseases on that individual. For example, patient can come in with just diabetes, then it's fine. But if he has diabetes, nephropathy, if he has hypertension, cardiac disease, you'll have to have multiple AI models syncing and merging with each other and working together. So how cost effective would that be? And of course, there are always infrastructure requisite questions. But at the end of the day, AI in diagnosis and prognosis is going to signal a paradigm shift in healthcare. We do recognize it as physicians. AI can detect and learn features from large volumes of imaging data using efficient algorithms, assisting clinical practice. It should and can foster personalized medicine and help reduce, importantly, diagnostic and therapeutic errors, and can correlate, importantly, novel features and recognize disease-specific patterns to gain innovative, scientific insights, and therefore contribute to better, care outcomes and improve the productivity and efficiency of care delivery. Thank you. It's been a pleasure. Questions? Yeah.
Yeah. Any questions?
When you put the challenges in AI, so you put that like there is descaling physicians. So why you mentioned specifically that?
No, see, with anything, it's not just about retina or ophthalmology. It's this is a phenomenon we're seeing everywhere. So in the olden times, you must have heard physicians of fathers and forefathers, they'd use just a microscope, they just use a stethoscope. Now people, cardiologists need a validation with the echo, with a CT scan and everything. So medicine is going more towards machine-based or diagnosis-based thing. So the skill right there, whether this would lead to some sort of descaling when everything comes laden on a platter to you, whether that will reduce the clinical nose acumen of the things, that is a question mark. And this is a raging debate, not just retina, but all scientific fora. So this is something which we have to balance. That while AI is a great tool for looking at and picking up pathology on a wide scale, on a population based device, but when the patient is sitting in front of you, you need to have that level of clinical volume of cases that you should have seen, and you need to have the clinical experience. So that's a very basic thing that we need to look at. So AI needs to be something which we have to use for mass screening and mass modeling.
Yeah, go ahead.
Hi, I have a very general question. Can you comment on the effect of high screen time on?
Yeah, actually, that is an important question, because in fact, I actually did a talk for NDTV, Gadget Guru, about 10 years ago with this guy, I forget his name. It is important, it is critical, because what you're seeing is with a screen, our eyes have been built to look at things in natural light. It's not been built to look at a screen. And what you're seeing from a screen is actually radiation. It's radiating light. And there is a high component of blue light. And blue light is deleterious to us. I didn't go deeper into the macular anatomy, but our maculae, why it's so sensitive is because there's a high concentration of a yellow pigment called xanthophyll, yellow. So blue light and these are complementary. So the more you subject yourself to blue light, over a long period of time, you could be doing some level of damage. In fact, actually, if you go and see your mobiles and all your laptops, there are blue blocking filters, blue blocking apps, and people are using that. And this is something we see a lot of IT folk in Chennai, coming over with strain. And that's actually one of the reasons why I put in that the CSR pathology also, working late at night and using a lot of screens. So that is deleterious. The long-term effects have not been quantified very well. There are just conflicting reports, but definitely it is going to harm your eyes if you do it for a very long time. There is in fact something known as gaming maculopathy. There was a kid, I think from somewhere in the Far East, where the child was using these laptops and these screens and doing intense gaming through the night for periods, and actually came in with almost complete blanching of the photoreceptors and severe degeneration. This is an issue. This is an issue for sure.
Following up on that, in the old days, you had cathode ray tubes, and also you didn't have computers, but you had TVs. And is it that the distance from a TV alleviates the damage?
At the end of the day, it's the number of photons that is hitting your eye. What wavelength is also an issue, as I mentioned, with specifically the physioanatomic correlation, where you have the high concentration of photoreceptors, which has a high concentration of macular xanthophyll, the yellow pigment, and then you're bombarding them through and through with blue light. So that is an issue. It's also the intensity as well as the the wavelength. So even when we operate, there are specific guidelines as to how much of illumination we can use inside our. When you saw that picture with us operating with the endo illuminator, a light is right there inside the eye. So even that, there is a regulation as to how much of light intensity can be used when we operate. Because as retinal surgeons, we do 1 hour, 1.5 hour surgeries for detachments and all that. So there is a regulation there too.
Okay, I have a question about the, you talked about the data heterogeneity part. supposing groups around the world are studying this, are there privacy concerns with creating a database of retinal? Are they identifying to the human subjects to share just the retinal?
So all data is, there are de-identified. They're de-identifiers. So that is always there. So we de-annotate patient.
I mean, for example, if it is an iris, then it is identifiable.
Sorry.
If it was an iris picture of the iris,
Okay.
then that is unique to an individual. So there may be privacy concerns with even sharing that.
We cannot completely mask out all the ethnic imprints on the clinical data. Yeah.
Okay. Yeah.
Mike, Rajiv. Go to Mike.
So what you asked was absolutely correct, that retinal image like the iris thing is specific for an individual. So there is this concern that the retinal image, so that's the reason now people are going towards synthetic generative AI, converting it to a synthetic image and then use it.
Yeah, thanks for that. That has actually been part of the theme of this on sharing human medical data confidentially, partly maybe by synthetic data. Yeah.
And also, one more. And also you mentioned that age-related macular degeneration, there is a difference between rural and urban population. Is there any difference for that? Why is that different?
So one is that there could also be a genetic heterogeneity, but then putting it down specifically to rural-urban divide, one would have to, implicate lifestyle factors as well as the diet factors. So I think Rajiv can talk about that. Rajiv, this is the paper from their side.
We did an epidemiological study on AMD that was more than 60 years, about 12,000 people. So what you are telling, there is a rural-urban divide, and it seems because the risk factors are sunlight exposure, smoking, tobacco use. I think those environmental factors will probably play a more role rather than genetic. The mutations are pretty known as far as AMD is concerned, unlike retinopathy, where you have a lot of things here. There are a couple of genes which are very much implicated, and probably even the therapies are coming out based on.
It would be interesting, Rajiv, from that point, like Dr. Mohan had said, to look at a population of patients who have just migrated from a rural to an urban scenario. That would be interesting to look at. But then, of course, one must understand these are all long-term effects.
So there was a study by Dr. Alan Bird, who looked into rural Italy, and he found suddenly the prevalence of AMD is increasing, wet AMD.
Okay.
And he attributed it to more of pesticides and other things in the discussion, but there's no proof.
Yeah.
As you rightly said.
Basically, what we were talking of is dry degeneration. That takes a long time to settle, which is why I said that genetic factors possibly may be playing a really strong underlying role.
Okay, any more questions? Okay, so let's thank Anand again for a
Thank you. It's been an
very
absolute
interesting
pleasure.
talk.